Hi everyone, I'm Dr. Chen from Joint Santo International Eye Center. Today we'll be discussing various disorders of the eyelid. After this session, I hope you are able to describe common lymphatic and inflammatory disease of the eyelids and identify common anatomic deformities of the eyelid. Before we go further with this topic, let's review the anatomy. The eyelids are thin folds of skin with muscles and fibrous tissue that protect the delicate structure of the eye. Skin is the thinnest tissue that gives eyelid great mobility. Beneath the skin lies loose connective tissue which can become greatly distant with fluid. Muscles of the eyelid include orbicularis ocular muscle, levator palpebral superior's muscle, and Mueller's muscle. The function of orbicularis muscle is to close the eyelids. Levator muscle elevates the upper eyelids, which includes the skin, upper tarsal plate, and upper palpebral conjunctiva. The fibrous layer contains tarsal plates and orbital septum. Tarsal plate is a hard tissue that supports the eyelid. Inside the tarsal plate, we have the meibomian gland, which produces an oily secretion to prevent tears from evaporating. Orbital septum is an important barrier between the eyelid and the eyeball. Underneath the eyelid, we come to the palpebral conjunctiva, which connects glands essential for lubrication of the cornea. Now let's discuss some lymphatic and inflammatory disease of the eyelid. Hordeolum is infection of the eyelid glands. When the meibomian glands are involved, a large swelling develops which we call internal hordeolum. The smaller and more superficial external hordeolum is an infection of the this or most gland. The main symptoms usually include pain, redness, and swelling of the lid. An internal hordeolum may point to the skin or to the conjunctival surface, while an external one always points to the skin. Most hordeola are caused by staphylococcal infections, usually Staphylococcus aureus. The treatment consists of warm compresses 3 to 4 times per day for 10 to 15 minutes. If the process does not resolve, then incision and drainage of the purulent material is indicated. We should make a vertical incision on the conjunctival surface to avoid cutting across the meibomian glands. If the hordeolum is pointing externally, we will make a horizontal incision on the skin to minimize scar formation. Antibiotic ointment applied to the conjunctival set is beneficial. Collagen is an idiopathic steroid chronic granulomatous inflammation of a meibomian gland. The patient complains of a painless localized swelling that develops over a few weeks. It may begin with mild inflammation and like the hordeolum, but it never has acute inflammatory signs. If a collagen is large enough to affect vision or for cosmetic reasons, excision is indicated. We make a vertical incision into the tarsal gland from the conjunctival surface, then carefully scrape out the gelatinous material and granulum epithelium. We can also inject steroid into the small lesions. If the collagen recurs, we have to do a biopsy since meibomian gland carcinoma may mimic the appearance of collagen. Blepharitis includes anterior and posterior blepharitis. They are both chronic bilateral inflammation of the eyelid margins. There are two main types of anterior blepharitis, staphylococcal and severe blepharitis. Often, both types are present. The patient complains of irritation, burning, and itching of the lid margins. We can find scales or granulation thinning to the rashes of both upper and lower eyelids. Posterior blepharitis is caused by meibomian gland dysfunction and alteration in meibomian gland secretion. Symptoms of posterior blepharitis can be related to the eyelids, tears, conjunctiva, and cornea. The lid margin becomes hyperemia with scarring of the tarsal conjunctiva, abnormal tear film, and vascularization of peripheral cornea. We can treat anterior blepharitis with antibiotic or sulfonamide ointment. For posterior blepharitis, we need long-term low-dose systemic antibiotic therapy or with topical steroid. The second part is about anatomic deformities of eyelid. Eyelid turning inward toward the eyeball is called entropion. It may be evolutional, cicatricial, or congenital. Involutional is most common as a result of aging and always affects the lower eyelid. Cicatricial entropion is the result of conjunctival and tarsal scar formation. Congenital entropion is rare and usually seen in Asians. Entropion usually coexists with trichiasis, which means eyelashes towards the cornea. Trichiasis can cause corneal irritation leading to ulceration. Conversely, entropion means inversion of the lower eyelid. The cause might be slackening of the orbicularis muscle due to aging or the seventh cranial nerve palsy. Treatment of both entropion and entropion will be surgery. Normally, the upper eyelid of an adult should cover the superior corneal limbus 1 to 2 mm. Ptosis is one or both upper eyelid covers more than 2 mm of the superior corneal limbus. It may be congenital or acquired. Neurogenic ptosis is caused by an innervational defect such as third nerve paralysis or Horner syndrome. Myogenic ptosis is caused by disorder of the levator muscle itself or by impairment of transmission of impulses at the neuromuscular junction. Aponeurotic ptosis is caused by a defect in the levator aponeurosis with age. Mechanical ptosis is caused by the gravitational effect of a mass or by scarring. Treatment for ptosis depends on the underlying cause and severity. Surgery is indicated for significant functional or cosmetic problems. In this session, we have learned some common infective inflammatory disease and anatomic deformities of the eyelid. We need to identify main differentiating features and treatment principles. That's all for today. Thank you for joining us.